Welcome to the Industrial Athletic Trainers Society VNS On Demand. We are excited to share with you value-added continue education programs. Stick around at the end, or check the video description for more details on how members can claim their CU credits.
All right, good morning, good afternoon, good day, wherever you are in the world. Thank you for joining us today in this next session of VNS25. Today with us, we have Dr. John Longfree. Dr. Longfree is a Senior Vice President at WorkCare Incorporated, which is a US-based occupational health, wellness, and absence management company. Dr. Longfree is the Medical Director at an industry-leading organization in Tennessee, and he has served and is currently serving as a consulting physician at numerous client companies. He formerly provided clinical oversight for WorkCare's 24/7 telehealth triage program. And Dr. Longfree is board certified in occupational medicine. He earned his Doctor of Medicine degree at the University of North Carolina, Chapel Hill, and his master's in public health at the same institution. He completed a fellowship in undersea and hyperbaric medicine and his residency in occupational medicine at Duke University Medical Center. Dr. Longfree is fluent in Japanese and is licensed as a private pilot. Also, side note, he is a killer BMX rider apparently, and is running the amateur scene. He speaks frequently at conferences, and his research has been published in peer-reviewed academic medical journals. Ladies and gentlemen, Dr. Longfree.
Thanks, Chris. Yeah, I just want to talk about BMX today since I after 35 years out of the sport, I got back into it yesterday with my kids and had an absolutely fantastic time. And I think I'm a contender. I think I'm going to do it in the old man class. I'm philosophically anti-PowerPoint, but I understand that that's kind of the epoch of history in which we find ourselves. So we'll go through this. I sort of sometimes think PowerPoint makes us dumber. So, but let's go through this and we'll have a little fun with. Hopefully, you walk away from this talk just thinking we had just a good time and it was an interesting subject and maybe changed your paradigm a little bit. So like, why are we here? What's the purpose of this discussion? And this is a talk that I've been giving for about 10 years now, maybe longer, on the subject, basically trying to convince people that the treatment of occupational injuries is a little bit different than an identical type injury, an otherwise identical injury that occurred off the job. And that may come as a surprise to many people. You're a human being. You have parts and pieces and components and arms and legs and so on. And so why should it matter whether something was injured at work or not? And I hope today to convince you, to sell you on the idea that you'll have better results if you look at it through a slightly different lens. So what I'm looking for today is a paradigm shift. I'm not making any money off of this. There's no financial conflict, and I hope to not introduce any bias other than to what I alluded to earlier. We're here just to share knowledge and my experience over the last sort of 20 years of doing this. So keep in the back of your mind, if you would, that whereas in the past we may have always wanted to order one more test or engage one more consultant or spend some more money to make somebody better, we're gonna try to shift that paradigm into the idea, maybe novel for many of us, that sometimes doing less is a way to get more. And also, to what extent do your moods, your preconceptions of things, your pre-knowledge of anatomy and medicine, to what extent does your mind influence your body? So just keep those in the back of your mind as we're going through today's discussion. So about, I don't know, I think it was about 12 years ago, maybe 15 years ago, Dr. Greeny, who's my boss, who owns WorkCare, he stumbled across this paper, and with great fanfare and excitement, called me and said, "You got to read this." And so I did, and essentially, what this paper did was validate what we had already learned through trial and error, treating, thousands, if not hundreds of thousands of occupational injuries. We just sort of over time learned what worked and what didn't. And these guys figured that out as well, but with more rigor. They described it in this it's quite an interesting paper, and I encourage anyone to read it. I can send a copy to Chris if Chris doesn't already have it. And it's not dry at all. It's just an interesting history of workers' compensation, which doesn't sound very interesting, but with lots of little vignettes on to bolster their opinion. But it's quite an interesting paper. It's one of my favorite in my field. I refer to it a lot. And the SPICE model that we're going to talk about today is the underlying sort of, what can I say, driving philosophy of everything at our company. Just some background, helps to have a little bit of background. Back pain is the number one thing that almost all doctors see. I mean, unless you're like a pathologist or I don't know, what other kind of doc wouldn't see much back pain, maybe a brain surgeon, or even they see spine stuff. So. But in any event, back pain is like the number one. It's the number one thing I see. Everybody gets back pain at some point. And I'm not going to read the slide, but just suffice it to say that there's a lot of money spent on backs. Very little of what we do is really based on science. It's based on more just people's consensus opinion. What you've learned over many years of doing it. Some things work, some things don't. So a lot of it's based on our intuition and our experience rather than, prospective double-blind randomized controlled trials. The highest level of evidence you can obtain in a very dry sort of medical study. Also underlying this is, and again, this is sort of just some background before we get into the meat of things. Disability rate is growing. You wonder why, and we'll get into that. A lot of workers' compensation injuries are musculoskeletal, and we have a group of athletic trainers today, and that's how that all got started. Is this realization that so much of the injuries are not chemical inhalation injuries or scratches to the eyeball or those sort of, they're in fact musculoskeletal injuries, especially with the aging workforce. But even a higher percentage of those tend to cause what are called our lost time incidents. Those days away from, OSHA calls them days away from work. But everybody else, if you're not working at OSHA, you call it lost time injuries, but they're synonymous and mean the same thing. We'll get a little bit into why the first world has such a high rate of disability due to back pain, and the third world has such a rather low rate. And that may seem surprising to you, but that is in fact true. In the third world, people don't tend to have as much back pain, and there's a very interesting story behind that. Hopefully we'll have time to discuss. I don't want to talk about it right here just due to time, but we can get back into that later if you like. It's quite an interesting story. So you've all heard of the 80-20 rule. So, that is that 20% of your problem children will cause 80% of the problems. And we see that for sure in workers' comp as well. So a lot of the costs are spent on things you can't really, things for which there's no objective tool. I always tell people that if you want to become a billionaire, define an objective tool that can measure someone's pain. So far, it doesn't exist. And I suspect that's because a lot of it is psychological, more than we sort of typically have come to believe. But there is no painometer, and that is part of the reason I think that we spend almost all of the costs on non-verifiable muscle and back complaints. If you're paid to be out of work, will you come back to work? The only time I've ever walked away from an initial sort of meeting with a potential client was when so I went to school in Chapel Hill, and after I graduated and everything, Chapel Hill called me through a contact and asked me to present to them, and they wanted to get a hold of their workers' comp costs. And so I went and presented to Chapel Hill, the city of the People's Republic of Chapel Hill, as we call it sometimes. I was with the safety manager, and I ended up walking out of the meeting, and pleasantly. What he told me is that normally when you're out on workers' comp, you get like 2/3 of your pay, but guess what? It's not taxed. Generally, depends on the state, I would assume, but generally it's not taxed, and so you get 2/3 of your pay, and so it's not taxed. So you're actually making, let's just say, close to maybe 85% of your take-home pay. But what the city council decided to do was they wanted to be kind to their fire, police, and utility workers. And so what they said is, okay, well, since you're only getting 2/3 of your pay, we're gonna pay for that extra third while you're out on workers' comp. That part of it would be taxed. The last third would be taxed. And so what happened was it came out to be that if you were out on workers' comp, you'd be making more money take-home pay-wise than you would if you were actually working. And so they had this big problem of police, fire, and utility workers that just staying out on workers' comp and sort of gaming the system and not wanting to come back to work. And that was the moment I said, look, if you have to fix that first. I'm not going to be able to fix this problem unless you fix that. And so keep that in mind. If you're paid to be out of work, you're going to stay out of work. Again, there's reason number one that we treat these work-related things differently. So the other thing is, imagine if you come home to find out that your son is on drugs, your wife has cancer, and your dog just died. All these sort of things could affect your threshold, your pain experience, your threshold to experience these things. Obviously, the level of discomfort is the physiological, the activation of the P fibers in your peripheral nerves. All of that can influence your level of pain. That's number one. But these other two things, 2 and 3, your psychological stress, all the others, the financial stress, all those things can kind of lower the threshold to your experience of pain. And so we see that a lot in workers' comp. People essentially bring in their baggage, their psychological and social baggage to the workplace. And so we're going to sort of focus on 2 and 3. And then, so for sure, the last little bullet point is, if you have anxiety and depression or some other depressive disorder, that can also lower your threshold for your experience, your personal subjective experience of pain. So let's introduce how we approach all of these problems. I like to use something called the SPICE model, and that's an acronym, and we're just going to go through the letters one by one, but there is a little bit of background to this. So originally, during several wars in the West years ago, the various armies around the world discovered that there were psychological sort of things that would disable soldiers that were sort of somewhat independent of their physical ailments or their physical injuries. They came up with various names for these, like war neurosis. And we'll get into more of those. The Israelis really looked at, the Israelis fight a lot of wars, as we all know. There's lots of wars ongoing, even today. And they looked at this quite in depth. And in the early 70s, they decided to throw everything at these soldiers to see if that could fix them. They would, if you were injured, they would throw psychologists and counselors at you, and surgeons and injection doctor, PM&R doctors, and all sorts of things at these soldiers to see if they could solve the problem and get them fighting again more quickly. But they failed miserably in that attempt, and that got them scratching their heads. So a little bit later, during the I forget what year the Israel-Lebanon war was, but it was several years later. They tried the pendulum swung almost to the opposite side, and what they did was they instead put medics, much like yourselves, they put them up in the front lines in these I think they called them like forward operating hospitals. So they were these MASH units, way up way up by the front lines. That would, pat the soldier on the back, suture up what wounds they had, give them a glass of water, give them a little encouragement, document everything, and then send them back. And they found that they could keep the soldiers more productive that way than with the previous method of spending a lot of money and resources on each individual soldier. And so think about yourselves. You in the on-site clinic of where you work at your factory or construction site or wherever that is essentially a MASH unit. It's a forward operating hospital that's utilizing this method of bringing the employee back to fighting status as quickly and effectively as possible. So this is why you're there. This is why this works. There's history there. There's long, 100 years of military history there, maybe longer, of them sort of figuring out almost empirically, without really trying to. It's almost serendipitous that they stumbled upon this. Many armies simultaneously did. It wasn't just the Israelis, but figured this out. The Americans figured this out as well. So you might say, well, soldiers are soldiers, workers are workers, but they're really the same. I mean, they're the same in many ways. They have to be fit enough to be healthy. You have to be, the whole system of IQs, which is very flawed, was sort of came about as a way to screen out recruits during World War II. Like, it wasn't really ever intended initially to be used to rank kids and adults against each other. So both are teamwork is required to be a worker or soldier. The government has two separate systems: the VA system and they have their own military medical system for active duty folks and reservists. But and then we have our workers' comp systems that are not federal in the way the military one is. They're state by state, and they vary greatly amongst state. There's usually three different sort of flavors of workers' comp systems: employee directed, employer directed, and then panel systems, and then some mix thereof. But essentially, that's that. There are these sort of entitlement programs. Psychological stresses correlate with injury claim rates. That's we're going to get into that in great detail with this next slide. Let's look at this. So things that drive disability claim rates oftentimes are things that are not even related to the work itself. They're psychosocial things like your performance record. Are you able to perform the job? If you're 4'11" and they have you changing light bulbs, that you might get a little down and you're down in the dumps about that. You like your job? Is your team supportive of you? What's the morale like? I think that probably 10 years from now, we're still going to have safety managers at sites, but I think that we might have morale officers. And what I suspect is that you will be the morale officer. In my opinion, morale is every bit, if not more important than safety. Now, it sounds crazy to say. Obviously, you need your machine guarding and you need to train people to operate, excavators and things. I get that. But when people bring their psychological and social baggage to work, that puts them at higher risk of being distracted at work and higher risk of serious injuries. And interestingly, I put some stars around this personal belief in supervisors. Whenever I have an employee come in now, one of the first things I ask, if it's a private area, of course, is how well do you get along with your boss? I mean, if they don't get along with your boss, watch out. The employee is going to have a delayed recovery, I promise you. But if they do get along with their boss and there's joking and banter back and forth and all that, that's a very good sign that things are going to go well for that case. That's been my experience doing this. So let's talk, we'll get back into this, but let's talk about SPICE. So, and we've got, how much time do we have, Chris?
We have until 12:15. So we've got, or 1:15 your time?
An hour, okay. So we have plenty of time. We'll finish early. Famous last words. So S is for simplicity here. So what does that mean? It's just like, keep things simple. Don't use a bunch of Latin terms and Greek terms. You can, that's fine, but just explain them when you do. So, everybody has back pain. We're just going to talk about back pain. Everybody has back pain at some point in their life. Typically they last less than 2 weeks. That's what I tell people. Almost nobody has true sciatica, like a true pinched nerve, a true, radiculopathy. That's very rare. But most people seem to think they have, and most people are told that they have that or may have that. So stop scaring people with these things and keep the term simple and keep a smile on your face and upbeat. And don't oversell these things and make people worry, because you're probably overselling it. I know that in medicine I'm guilty of this too, but I know that in medicine that we're trained to kind of imagine the worst possible thing that could be happening. Usually that's cancer, and then try to rule that out first. But really, like, the things that we see in the workplace are usually sort of plain Jane bread and butter, dime a dozen back pain and other minor things. So no need to oversell it and scare the employee unnecessarily. Keep it simple. In the old days, to take a psychological twist on this, what we now call PTSD had all these other names. So you can look through those. And I always think, like, imagine coming from the planet Mars and trying to figure out what some of the vague language is that we use in English. It would be quite daunting to figure that out with direct translation anyway. So just, again, avoid complicated words. What we oftentimes say is simple therapies lead to simple outcomes. Or simple terminology leads to simple therapies, leads to simple outcomes. So, the more complicated you make things, the more complicated it'll become. Like, people will rise to the expectations you give them. Practitioners frequently disagree with their. Okay, this is kind of interesting. So some orthos did a study. This is like 20, 25 years ago, and they found that depending on the settlement that the employee would get from the claim would depend upon what terminology was used, what words were used in the MRI report, in this case the CT report. This is from a long time ago, and they found that if you use the scary word herniated disc, you got more money than if you just said simply, oh, you have a protruding disc. It was, even though those are the same thing. A disc bulge, of course, is not the same thing, but I just added that. I kept that in there just to show you the kind of the numbers involved. A disc, who cares? Disc bulge, everybody's got a disc bulge. That's like half of people have disc bulges in their L spine, and they have no pain at all. I mean, I've heard anywhere from a quarter to a half of people above the age of, like, what is it? Some of you may know better than me, but it's like 25 years old, maybe 30, that have disc bulges, but no pain at all. So if you see a disc bulge on an MRI, who cares? They're super common. And here you go. We all know that elderly guy with the wretched looking spine X-ray that has no complaints. And then we all know the young person that has radiculopathy and a totally normal, spine X-ray. So spine is so common and so tricky. It makes it very complicated for certainly for workers' comp boards and state to adjudicate claims. So simple therapies lead to simple medications, lead to simple outcomes. So just keep it simple, and the employee will get better. Other things that can affect your outcomes. This is with lumbar fusion, so surgical, titanium rods being put in the back, low back. Think about it. So what would predict your outcomes? Okay, well, if you have a lawyer, you're obviously suing somebody or your employer, so you're not going to get better quickly. You're probably told not to get better quickly. If you're okay, so there are like weekly pay caps on workers' comp. They're like state mandated pay caps. So there's a certain maximum amount of money you can make while you're out on workers' comp. So if you're less than that, you'll stay out longer. So if you're, a low paying hourly rate type, like, janitorial services or some of the lower skilled type work, those folks you might have a harder time getting them to come back to work because they're happy with getting their 2/3 of their pay. Not happy maybe, but they're tolerating that 2/3 of their pay. But if you get somebody that makes a lot of money that gets hurt, they're going to hit that cap so quickly they're going to want to get back to work very quickly. And we see that with higher paying physical jobs in the trades, especially. Certain types of like elevator mechanics and other things, high school degree guys that are making like a couple $100,000 a year fixing elevators. Those guys will do anything they possibly can to get back to the workplace, even if they're absolutely not ready. So keep that in mind. And then, of course, total medical costs. That's a no-brainer. If you had $1 million surgery, you probably had a lot of stuff done. So you're going to take a little bit longer to get back. But these are sort of like non-physical things that can delay your recovery. Again, workers' comp is different. The P, proximity. So here it is again. You guys are all the P. You're the proximity. You're the forward operating hospital. You're the morale officer. And this is I don't want you to think I'm just joking around here with this morale thing. Morale is every bit as important as safety, in my opinion. If the morale of the workplace is low, everything goes to pot. Everything is just bad. So keep that in mind. Keep everybody's morale up, yourself included. You want to keep them emotionally, physically, and emotionally close to the workplace as possible. So I have this weird this last bullet point's kind of strange. Okay, you might find it strange, but I'm going to explain it. So when people ask me, who am I? Do I say, I'm a white male, I'm half Anglo-Saxon and half French Canadian? Or do I say I'm a butcher, a baker, and a candlestick maker and a carpenter? People describe themselves by their occupation. So now imagine that this guy goes to the doctor, this butcher, baker, or candlestick maker goes to the doctor, that we send him to the offsite clinic, and the guy is written out of work. So now, unwittingly, that doctor at the clinic has sort of, if you think about it, has kind of stripped that baker, candlestick maker, of his identity. I'll pause. There's a dramatic pause there. We've stripped that person of their identity, and now what fills the void is the identity of the disabled person. So there's this shift. There's this almost like psychological switching of gears that shifts them into reverse, into the disability mindset, and it is very powerful. So you may have noticed, if you've been in workers' comp and occupational health for a long time, that we don't call them patients. We don't call the people with whom we work, the people that get injured, we don't call them patients. You do that in a hospital for the disability mindset types. In our work, we just call them workers, employees. You'll see that in the paperwork a lot. We have a 34-year-old, employee, blah, 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 with, left ankle pain, yada, yada. And so this is why. I mean, and we did it sort of unconsciously without realizing it for many years, but this is why. We don't want them to feel like they're patients. Yeah, their back hurts or their ankle hurts, whatever, but they're still an active and productive member of the American workforce. They can still contribute. So there you go. So that's why it's very important. That's why this is important. Our job, our work is how we define ourselves, for better or for worse. Maybe it shouldn't be that way, but it is. Boeing, this is my second favorite study, maybe my first, I don't know. But in our field, so Boeing looked at, like, I can't remember if it was 1,000 or 10,000. I think it was like 10,000 cases of back pain through all their sites worldwide, or most of them. And what they found is that they looked at whether you were fat, whether you were thin, whether you were black, whether you're white, whether you're whatever, whether you had previous surgery to your back, whether you were this, that, or the other. They looked at all these different factors. It was like tons of factors, lots and lots of factors. Then they did a linear regression on the data. That's a biostatistical term, to figure out what's sort of a statistically significant variable, a causative variable. And what they found was quite interesting. It didn't matter whether you're fat or thin or had previous back surgery or whatever. They only had one significant factor. It was whether, and this is where I ask you to raise your hands and tell me what you think it is. Many of you heard this talk before, so I won't belabor that point. But essentially what they found is that if you don't like your boss, you'll be more likely to make a claim, a workers' comp injury claim. Think about that for a second. That has nothing to do with the physiology of that person. Again, another dramatic pause here. So keep that in mind. That's why I ask people, do you get along with your boss? It's a very important question. It may be the most important question to ask. Because again, I've said it before, if they don't get along with their boss, watch out. They're not going to get better. And then I could sort of skip all these these probably read these while I was talking. It's essentially, if you're treated closely, if you get along, if you're psychologically close to your work, that's where your friends are. That's where, work is therapy, we say. That's sort of a work care. We say work is therapeutic. That's a work care sort of mantra. These are all the values, these good things that you get out of work. A lot of it's social, though. Your friends are there, you hang out, you chat, you have all this sort of, you get along with people, you learn new skills, all these things. And when you're away from all that, this is why I like to keep people at work, whether they're injured, whether it's an occupational or non-occupational injury, is that they tend to devolve into negativity when they're sitting by themselves. Again, I'm talking about people that like their work. If you hate your work to begin with, maybe the opposite. But in general, by and large, more often than not, we tend to see when people are away from work, it's bad. And the data supports this. When you're disabled and out of work for 6 months, you're basically not coming back after that. That's the magic number, is 6 months. After 6 months, you really just can't get people back, and that's been my experience too, just practically speaking. Yeah, again, morale. Keep people ready for the physical demands of the work through ergonomics and work hardening and pre-placement stuff. Prepare them for the work, get them ready to the extent possible. I know there's not a lot of opportunities sometimes or resources available to really put people through the pre-Olympics training program that they really need, but do the best you can with the resources you have. Always accommodate restricted duty when possible. Get them back quickly for injured workers. I understand why safety managers don't want to bring back non-occupational injuries. They don't want to buy the injury if the person significantly aggravates the non-occupational injury at the workplace. When you do that, oftentimes the company has to buy the non-oc injury, and they don't want to do that. So they want to keep the non-occupational stuff away as long as possible. So they're 100%. And I sort of understand that. That's an administrative reason, though. Probably should bring them back, but it is what it is. System is broken. Immediacy. You want to jump in there. Basically, the bottom line is, this is what I see a lot. You have a guy, worker, whose wife is a nurse. And then they get, I don't know, like an electron bursitis. Let's say something that is a big nothing burger, but looks really ugly. And it's electron bursitis. It's that big, squishy thing on the back of your elbow that you see in guys above 50. And essentially, what happens is if you don't jump on that injury quickly, he's going to go home to his wife. And who's a nurse. She's going to tell him to go and this is a Friday afternoon, I forgot to tell you. And she's going to tell him to go to the emergency room. He's going to go to the emergency room. And by the time on Monday, when you learn about this, he's already had 2 days of lost time, which is the worst thing that can ever happen to a company aside from a fatality. And other than a bankruptcy, I guess. Essentially, it comes as a disaster when we sort of let things wait until Monday. Before, I'll see you on Monday. It's Friday. And these guys you need to jump in there quickly, talk with them. And you'll see that those of you that work with me directly, you'll oftentimes hear me say, well, let's not wait till Monday. Let's just go ahead and just see them. It just take 20 minutes of my time. It's no big deal. We'll see them. And then now you've basically just inoculated the guy against disappearing and going AWOL, going off the reservation to the emergency room and getting, a Norco prescription and days away from work and so on and so forth. So jumping in there quickly is huge. Speaking of that, so Pan Am, Delta, two crashes, and they're described in the paper. One was at Louis Armstrong in New Orleans, and one was in, I think it was Dallas, Fort Worth. This is like the mid 1980s. Both wide body jets, both crashes on approach in bad weather, as I recall. And like 200 people in each of the planes died. Delta flew in all the family members to Texas, I think it was, put them up in hotels, flew in counselors and grief counselors and clothed them and fed the people, the family members of the deceased and the victims. They did all these supportive things. Pan Am, on the other hand, lawyered up. It was radio silence from Pan Am Legal. Don't talk to the survivors' families. Be quiet. Which one of those companies still exists? Actually, the Pan Am name was just revived, in case so I'm not technically correct on that. But Pan Am essentially got sued into oblivion, and they no longer exist. Delta is one of the largest airlines in the world. Okay. Immediacy. So, yep, just jump in there quickly. You don't need to read all this, but just jump in there quickly and you'll have better results. C is centrality. This one confuses people sometimes, but it shouldn't. It basically means let's keep everybody on the same page. We see this we see centrality problems in certain markets in the United States, like Manhattan, Long Island, that area, around the Chicagoland area, Hawaii, and some places like around Seattle, and other places around the country too. So what's going on there? is that the employee can oftentimes go wherever they want in certain states. Those are called employee-directed states. When they get injured, they can go wherever they want. They don't have to go to the workers' comp doctor at all that sees sees work injuries regularly. They can go to their primary care, who obviously has different priorities than we do, and then that doctor sends the employee to their spine guy friend, and then they get an injection, and then that guy sends them to the neurosurgeon, and then that guy sends them to the neurologist, and everybody gets a cut of the pie. And essentially what that means is that workers' comp costs are unnecessarily high, and the employee eventually gets confused, and because they're getting told different things by the different doctors who aren't really speaking directly to one another. And now you've got some feeling that, oh my gosh, something must indeed be seriously wrong with me because no one can find it. They keep sending me to these other. What really is going on is it's financial corruption. It's medical corruption is what's going on. But anyway, so I digress. You're going to be kind of like the air traffic control. Frankly, that's going to be you. It's not going to be some case manager nurse at the workers' comp insurance carrier. They help and nice to have, but really at the end of the day, that nurse, that workers' comp case manager doesn't know this employee the way that you do. So at the end of the day, I suspect that you're going to be air traffic control, kind of explaining the flight path of what to expect to your injured employee. And again, that's, morale is important. You maintain the morale, try to make sure everybody's on the same, explain what to the employee, what's happening, what their doctor is saying. It's going to sort of fall upon you to do that, unfortunately or fortunately, if you enjoy this stuff. And that's kind of centrality in a nutshell. Basically, just make sure everybody's on the same page and the employee doesn't get confused. E, this is my favorite. Okay, we're coming to the end here, the finale almost. So E is expectancy. Anybody who's been on a call, an injured worker call with me, may remember that I always try to give the employee an expectation of how long they're going to be sore, how long their soreness or their pain will exist. Even if I have a little clue, I will give them a number anyway. And to my chagrin and surprise, I've discovered that employees will rise to the expectations that you give them, almost like soldiers do. Like if you push them just a little bit, and say, hey, you're going to get better within 3 weeks, and you're convincing of that, and you've sold it well, they will get better in 3 weeks. It's a mind over matter kind of thing, and I don't know how it works, but people will certainly do that. So for like shoulders, I tell them, look, like if your shoulder's going to take a few months, like don't panic at the 30-day mark. I found that 30 days is like sort of a magic number for some reason. If people are sore for a month, they start to panic. So, just put it out there in the beginning. You're going to be sore for 3 months. Tennis elbow. I don't think I've ever seen a case of tennis elbow resolve in less than like 3 or 4 months. And 3 months is being generous, I think. I mean, these things, they just take a long time. So, give them some sense of how long they're going to be sore, and you'll have a better result with that. Again, this is my favorite, expectancy. Voltaire, everybody remembers Voltaire. Maybe you do or maybe not. He wrote, what's that book about the Lisbon earthquake? It's on the tip of my tongue. He wrote like 30,000 volumes, and the only thing anybody remembers about him is that one book he wrote. It's on the tip of my tongue. Spit it out, anybody, if you know it. About the 1762 Lisbon earthquake that wiped the Portugal off the map as a world power. But anyway, so it's mind over matter. You can't really separate your mind from the body, although that's what we got from the European Enlightenment, and Voltaire was one of the great examples of the European Enlightenment, is that we moved from the world of spirit to the world of matter, and but that may have been a wrong turn, and that in fact they're inseparable. So anyway, with that, We have a few other slides here that we can sort of just glance over here. And the VNS networking challenging code word is diameter. Everybody get that? So if you have any questions, either get them to Chris, or you can, some of you clearly work with us, so give me a call and we'll happily chat. Let me, how do I do this now? So I stop sharing and we're back. Are there any questions that anyone might have today?
Yeah, what kind of questions, comments, thoughts, discussion? This is really good. This is like the 10th time I've seen this talk. So I enjoy it every time, and I feel like every time I pick up a little something else. Thanks, Tina. Yeah.
Thank you. All right. I appreciate it. This is in the sinew of my soul. This is what drives our entire company. We love it. But sometimes it is hard to get across to people that this isn't the hospital. This isn't the hospital setting. We don't want to coddle the folks too much. They will. These are adults. They will do great if you let them. And also keep your employees happy to the extent possible. It's very important. Thanks, Igor.
And I think there's a lot of good stuff. Just to comment there, a lot of new things that we're learning about modern pain theory and how it's applied, the psychosocial aspects of it, way more than just purely tissue. And I think this speaks to that a lot. This whole talks a lot more about the psychosocial aspects of pain and disability, especially. When I was transferring some of the stuff over, I was looking through and actually pulled up those papers and pulled some of the research papers that went behind the SPICE paper. A lot of really interesting stuff out there, a lot of good stuff to read about. Other recommendations do you have for things to dive a little bit deeper into that?
That's it. I mean, I would start with just reading the SPICE paper. Like I said, it's not a dry research paper at all. It's quite fun to read and interesting, lots of vignettes. And I just gave you a few, like a couple of them. Chris, you've read it. And there's lots of things that just make you go, huh, this is the purpose of that paper was to, it's very good. This is a very good paper to orient people that are coming from so an athletic trainer, where if you got somebody coming from the university setting, right, we're treating literal athletes and students and, or sports stars into the occupational work where the priorities are clearly, they're a little different. And, you have all these other layers of EHS and OSHA and, the productivity of the plant and the aging workforce and all these things that are a little different. I find that this talk or this paper, really, you should read the paper. It says everything I said. The paper really is a great way I haven't found a better way to orient what I would call outsiders coming into our industry.
Nice.
Anyway,
I also like that you called us the air traffic controllers and connected us with another ATC. So we got their certified. I like the little parallel there.
The king of puns over here.
Yeah.
All right. Take care. Be safe. Drink milk. Don't run with scissors. And wear your seatbelt, everybody. And we'll see you later.
Awesome. Thank you very much, Dr. Lockery.
Thanks for having me.
This concludes the IETS On Demand Continuing Education Program video. To claim your CU, you must be a member of the Industrial Athletic Trainers Society and complete the form Claim Your CU found in the YouTube description. If you have any interest in learning more about what the Education Committee has to offer, reach out to the email address on your screen. If you would like to volunteer your time to speak on a topic that interests you, please reach out. Thank you and stay safe.